dear friends, the topic is toxic effects of drugs. So, again, let's have a look at a specific case. Just listen to the case and try to understand how disease symptoms and drug adverse effects intersect in this case. So, this case is about an 80-year-old piano teacher with a progressively severe right leg pain over a period of 5 to 10 years. And her pain and fatigue is progressively increasing. So she visits the physician and severe osteoarthritis of the right hip is diagnosed. She is scheduled for elective replacement of the right hip with a prosthetic joint. So this is the short introduction of the case. So what happens afterwards? Total hip replacement is performed without immediate complications. And during the first few days after the operation, she was started low molecular weight heparin anticoagulant. You see here example enoxaparin, and an oral anticoagulant warfarin, because she will be bedridden after the operation, and prophylaxis is needed against deep vein thrombosis. And 6 days after the operation, she develops severe pain in the area of operation. So what is seen on the right lateral hip and also on the buttock swelling on physical examination. A complete blood count reveals significant blood loss, and she's taken back to the operating room, and this hematoma, the bleeding accumulated around the operation site, and this was evacuated. So what do we see here? The anticoagulants, which prolong the bleeding time, their adverse effects have occurred mixed together with the operation. Although the hematoma does not appear to be grossly infected, so they send it, and the culture results is Staphylococcus aureus growth was observed. Since now there is infection and joint infections, these prosthetic joint infections are difficult to treat without removal of the prosthesis. An aggressive antibiotic treatment was started. So here you see two important antibiotics, vancomycin and oral rifampin. 2 weeks of antibiotic treatment was scheduled, and she tolerates the first 2 weeks quite well. Then they switched to treatment with ciprofloxacin and rifampin. You see here that rifampin is well tolerated together with vancomycin, but when ciprofloxacin was started, then 36 hours after this switching vancomycin to ciprofloxacin, the patient had fever 39.4 degrees centigrade and extreme weakness. And what can this fever be due to? It can be due to the disease, the infection, but also drugs can induce fever. So they aspirate the operation area, and they obtain a scant amount of straw colored. So this is non-purulent fluid. So again, she was admitted to hospital for close observation. And 12 hours after her admission, she is still getting ciprofloxacin treatment. She develops an extensive maculopapular rash on her chest, back, and extremities. So what they do, they discontinue ciprofloxacin and rifampin and restart vancomycin. Remember, she could tolerate vancomycin. So with ciprofloxacin, we can see either fever or rash at a rate of 2%. So gradually over the next 72 hours, they discontinue ciprofloxacin and restart vancomycin. Over the next 72 hours, her temperature returns to normal and her rash begins to fade. So as you see here, upon withdrawal of ciprofloxacin, uh, these symptoms, fever and rash, fade away. And there is no growth in the culture of the right hip aspirate. So she's continued on vancomycin as a single agent for the next 4 weeks without incident. Rifampin is restarted again without any incident, and the 12-week antibiotic course is eventually completed using another combination of sulfonamide and rifampin. So you will learn all these drugs in the next year. Uh, but here, what is important is to uh, understand how drug adverse effects may complicate the uh, picture. So, 4 months after her hip surgery, the patient is back to her daily life and making slow but steady progress in her rehabilitation program. So, at the start of this toxicology lecture, I should mention the famous saying of Paracelsus: "What is there that is not poison? All things are poison, and nothing is without poison. Only the dose permits something not to be poisonous." So, dose, the very important component of pharmacotherapy, then determines the toxicity of the drugs, as stated by Paracelsus. So, as you learn the drugs in the following years, so you learn many names, many prototypes at phase 3. You will see that each drug is a potential poison, and many factors contribute to this toxicity, either genetic predisposition, age, pre-existing conditions, environment, inappropriate use and inappropriate administration, and drug-drug interactions. They all contribute to toxicity. So, pharmacology intersects with toxicology when physiological response to a drug is an adverse effect, is a side effect, in other words. A poison is any substance, including any drug, that has the capacity to harm a living organism. So any drug can be a poison if not used properly. Poisoning generally implies that damaging physiological effects result from exposure to pharmaceuticals, illicit drugs, drugs which can use physical and psychological dependence, or chemicals. So in this part, I will explain toxicokinetics and toxicodynamics. So this slide summarizes these two terms. So when a drug is externally applied, then the individual is exposed to the drug. And within the body, it reaches a certain concentration in certain tissues and also at cellular levels, which will then interact with their receptors and cause a response. This may be an early response and a late response, and which may lead to irreversible pathology. Then this lower part is considered under toxicodynamics. So, how do we define toxicokinetics and toxicodynamics? Toxicokinetics is the pharmacokinetics of a drug under circumstances that produce toxicity or excessive exposure. So, um, if a drug under the circumstance which produce toxicity or at excessive exposure, it will display different pharmacokinetic properties. Toxicokinetics may differ significantly after poisoning. Many pharmacokinetic parameters may be altered, and accordingly, treatment decisions and prognosis may be changed. What is toxicodynamics? It is the molecular, biochemical, and physiological effects of toxicants and their metabolites in biological systems. So let's have a look at the example of aspirin. Aspirin, if taken at low dose, it has an elimination half-life of 3 hours. But if it is taken at a high dose, then you see the elimination half-life is prolonged. For this reason, we see that aspirin has a dose-dependent kinetics. Its half-life may be prolonged at high doses. Why? Because at low doses, aspirin is conjugated with glycine, glucuronate, or oxidized to gantisic acid. But at high doses, due to metabolic enzyme saturation, it is eliminated at a constant rate with zero order kinetics. So, with a few drugs, such as aspirin, you see in the graphic, ethanol and phenytoin, the doses are very large. Therefore, the plasma drug concentration is much greater than a KMR and drug metabolism is zero order, which means the metabolism enzymes are saturated and elimination is not dependent on the concentration but on the availability of the biotransformation enzymes. With most drugs, with plasma drug concentration is less than this Km, and drug elimination is first order, that is proportional to the drug dose. So aspirin at higher doses, as you see, have altered pharmacokinetics. So, if we continue with toxicokinetics of aspirin, aspirin overdose at overdose, time to peak concentrations may be delayed. So, it may be prolonged to 4 to 35 hours. Why? Because at overdose, aspirin causes a pyloric spasm, which delays the entry into the intestines. Aspirin is absorbed both in the stomach and in the intestines. And if the patient is using enteric coated aspirin, as you see in the right hand side, some bezoars can be formed, stone like formations, and this reduces the effective surface area. And when it is reduced, absorption is also reduced. So, paracetamol example. Paracetamol at therapeutic doses can be metabolized through various pathways. You see, it can be conjugated with sulfate or glucuronate, and if there is enough glutathione, it can be this toxic metabolite, NEPQI, is bound by glutathione and no toxicity will occur. But if paracetamol is taken at overdoses, what happens? Glutathione depletion occurs, and NEPQI is metabolized through this pathway, which leads to which attacks then this toxic metabolite attacks the macromolecules like RNA, DNA, important enzymes, and will cause cell death in the hepatocytes. So doses are not important. I give you the doses for you to compare. So paracetamol is an important analgesic drug. The therapeutic dose is usually 4 to 6 tablets per day. So the levels may change in children and adults. And we have maximum recommended daily doses, and there is an upper limit for a daily dose. So the toxic dose, of course, as I explained in the previous slide, may differ according to the baseline glutathione levels, the detoxifying agent. So toxicity may be is unlikely if a single dose of less than 150 milligram per gram is taken by a child, or in adults 7.5 to 10 gram is taken as a single dose. And with single ingestions, over 250 milligram kilogram or over 12 gram per day. And if it is taken more than 350 milligram per kilogram, then the patient will experience severe liver toxicity. And for this treatment, we use N-acetylcysteine, which is a glutathione precursor and which can act also as a glutathione substitute. Here you see the isoniazid metabolism and hepatotoxicity. Isoniazid is a drug used in the treatment of tuberculosis. Isoniazid is acetylated by NAT2 to acetyl isoniazid and then by hydrolysis converted to acetyl hydrazine. If when it is converted by acetylation to deacetyl hydrazine, this metabolite is non-toxic. And if it is oxidated by CYP2E1 to other metabolites which are hepatotoxins, then they may cause hepatic necrosis. For this reason, if the patient is a slow acetylator, this pathway is working slowly, then acetylhydrazine will be shifted to this pathway and hepatotoxins will be produced. And if they can be conjugated by glutathione, they will be excreted. But if glutathione depletion is present, then they will cause hepatic necrosis. So let's understand adverse drug effects, toxicodynamics. Let's think about an histamine type 1 receptor antagonist. When we use such drugs, H1 receptor antagonists, we use them in allergic disorders. And our intended tissue is postcapillary vessel endothelium. And we want to inhibit increased permeability, so we want to reduce the symptoms of, for example, allergic rhinorrhea, allergic sneezing in allergy. But this drug can also act on an unintended tissue like brain And so antagonization of H1 receptors in the brain will cause somnolence. Statin example. The intended tissue is liver. It's an anti-cholesterol agent used in dyslipidemias. We inhibit HMG-CoA reductase, which is important for cholesterol synthesis. The intended tissue is liver and it inhibits cholesterol synthesis. But the unintended tissue, like muscle, statins cause rhabdomyolysis, muscle rupture, and myositis. So this figure summarizes intended tissue and unintended tissue effects. Here is the drug. Drug is metabolized to its metabolite. They can act on intended receptors and unintended receptors in the intended tissue. Also, the drug and its metabolite can act on intended receptor and unintended receptor uh, in the unintended tissue. So what will be the results? If the drug and its metabolites acts on the intended receptor, then we will have the on-target adverse effects when those too high and chronic activation or inhibition effects. And when the drug acts on the unintended receptor in the intended tissue, then these will be called off-target adverse effects. So incorrect receptor is activated or inhibited. And if the drug or its metabolite acts on the intended receptor uh, in the unintended tissue, then on-target adverse effects will ensue. Correct receptor, but incorrect tissue. When the dose too high, chronic activation or inhibition effects. And also, drug and its metabolite will cause off-target adverse effects when it acts on the unintended receptor. Let's understand this phenomenon in another example. I started with histamine type 1 receptor antagonists, which we also call H1 antihistamines. So they act on various receptors in addition to histamine receptors. What are these? Cholinergic receptors, alpha adrenergic receptors, serotonergic receptors, and histamine receptors. So these drugs have a low specificity, interacting not only with histamine receptors but also with other receptors. But let's explain on-target intended tissue effects. We use this drug as an anti-allergic drug against allergies. So our target is histamine type 1 receptors on bronchial smooth muscle. For example, in asthma, histamine is released and it causes bronchoconstriction. So we want to block this receptor. And also in blood vessels, if we block the H1 receptors, we will inhibit the increased permeability. But on-target unintended tissue is the H type 1 receptor at central nervous system, and it will cause somnolence. Now let's try to understand toxicodynamics. I will give examples of harmful immune responses, not only drugs acting on the receptors will cause the adverse effects, but drugs also can induce adverse effects through immune responses. So, drugs are xenobiotics. They may be recognized as foreign substances. Drugs with a mass of less than 600 daltons are not direct immunogens but act as haptens. You see here the hapten molecules, and this is the plasma protein acting as a carrier molecule. And here you see the hapten carrier conjugate. So, what is a hapten? It's a small molecule, less than 600 daltons, that can elicit an immune response only when attached to a large carrier molecule, such as a protein. So, I said I will explain harmful immune responses. So, I will mention 5 types of harmful immune responses. So, first, let me explain type 1 hypersensitivity response, which we call anaphylactic reactions. So, here, hapten is bound to the protein, and also the immunoglobulin E with the Fc portion binds to the receptors which are available on mast cells or basophils. And if the Fab portion of the antibody molecule you see here binds the antigen presented by bound to this protein, then what will happen? Various mediators will be released and cause vasodilation, edema, increased permeability, and inflammatory response. The examples for type 1 hypersensitive reactions is penicillin allergy, and the main targets are gastrointestinal tract, food allergies, the skin, urticaria, and atopic dermatitis, and the respiratory system, rhinitis, asthma, bronchoconstriction, and the vasculature. Type 2 hypersensitivity response. Other names antibody-dependent cytotoxic hypersensitivity and cytolytic reactions. In this type of hypersensitivity reaction, a drug binds to cells and is recognized by an antibody. Type 2 reactions are mediated by both IgG and IgM antibodies, which activate the complement systems. And the target tissues are the cells in the circulatory system. And as you see here, the antigen binds to the red blood cell. And antibodies then are bound, IgG and M, to red blood cell. Then they activate the complement system and cause RBC lysis, or the RBC will be removed by the endothelial system, and they will cause RBC lysis. So the examples which we can give for this type of harmful immune responses are penicillin-induced hemolytic anemia, quinidin-induced thrombocytopenic purpura, and sulfonamide-induced granulocytopenia. Third type of hypersensitivity reaction we call immune complex mediated hypersensitivity. So, generation of antigen antibody complexes subsequently fix the complement. Antigen antibody complexes are deposited in the endothelium and start a destructive inflammatory response, and we call this serum sickness. Antigen and antibodies form complexes, and these complexes are deposited in the tissues, which will then fix the complement, and here the inflammatory response will start. Here, examples of third type of immune responses. So, cephalosporins, again, beta-lactam antibiotics, including penicillins, some anti-seizure medications, and as well as infections can cause this serum sickness. What are the symptoms? Urticarial skin eruptions, arthralgia, arthritis, lymphadenopathy, and fever. These reactions usually continue for 6 to 12 days and then subside if this offending agent, whether it's the cephalosporin or others, is discontinued. Type 4 hypersensitivity reactions. So here, heptan-bound protein will be phagocyted by the antigen. We call this also delayed type hypersensitivity reaction. Type 4 reaction is mediated by this T lymphocytes and macrophages. An inflammatory reaction is generated. Then, when T lymphocytes are activated, lymphokines will be produced, and neutrophils and macrophages will be chemo-attracted. And there will be, if there is this massive reaction, cytokine storm, it can lead to fever, hypotension, and even organ failure. Type 4 hypersensitivity response, for this type of hypersensitivity response, the typical examples are contact dermatitis. You see here, eaten by poison ivy rash or latex allergy, and tuberculin skin test reactions, and granulomatous inflammation, allograft rejection, graft versus host disease, and autoimmune hypersensitivity reactions can be given as examples. I will give you another case study. So it was important to be involved with clinics as earlier as possible in medical education. For this reason, I'm giving you case studies you understand over the case studies. This is about a 75-year-old woman with a history of hypertension, Parkinson's disease, osteoporosis, trigeminal neuralgia. So you will learn all these diseases starting in phase 3. So she needs to be evaluated for fever, rash, and skin pain. So she has multiple disorders. She has osteoporosis, loss of bone, and central nervous system problems, and also cardiovascular problems. Her widespread skin eruption started 3 days ago on her chest and spread centrifugally. She also reported a dull headache, and her eyes felt sore and scratchy. Her medications included hydrochlorothiazide. So when did the symptoms started, this skin eruption? 3 days ago. What are her medications? Hydrochlorothiazide, she's taking for hypertension. Carbidopa, levodopa, she has Parkinson. Vitamin D, she has this osteoporosis problem. She had been started on carbamazepine for her trigeminal neuralgia 6 weeks ago. This had been recently increased to 200 milligram twice daily. So, physical examination revealed an anxious and uncomfortable woman with widespread eruption. And there are erythematous macules on her face. You see the macules, and chest and arms blanched with diascopy, sporadic lesions. You see when it's tested with diascopy, you see the blanching, and sporadic lesions on the lower legs, which did not blanch entirely but were purpuric. And cervical axillary lymphadenopathy, and the lab findings. And biopsy is also taken, and they detected eosinophilia. So now what is important for you at phase 2 is Which of the following is the most likely diagnosis? So, if you had known these diseases and could make a differential diagnosis, you could have decided that symptoms of skin pain and scratchy eyes associated with fever and lymphadenopathy is indicative of a severe drug reaction. And in this case, what you see here is a DRESS syndrome, drug reaction with eosinophilia and systemic symptoms. And this DRESS syndrome is thought to be mediated by T cells. It's a severe idiosyncratic multi-system reaction to a drug characterized by fever, skin rash, lymphadenopathy, hematological abnormalities, and internal organ involvement. Type 5 harmful immune response is also called stimulatory hypersensitivity. What you see here is that um, a thyroid stimulant hormone is produced by the pituitary gland and stimulates the thyroid cell to produce thyroid hormones. In this type of hypersensitivity, antibodies are produced with the property of stimulating specific cell targets. So you see, now in these patients, specific antibodies against this receptor, TSH receptor, is present. And they stimulate the thyroid cell to produce the hormones. What is the consequence? Unregulated overproduction of thyroid hormones. As a result, the patient develops the Graves' disease. So the pathogenesis includes antibodies that stimulate the thyroid stimulating hormone receptor, leading to overactivity of the thyroid gland. So, how we define toxicokinetics and toxicodynamics. So, each drug, depending on the condition it's administered, its dose, pharmacokinetics may differ, and also drug response may differ. So, these two, toxicokinetics and toxicodynamics, can be investigated, of course, under many subclasses like pharmacokinetics for absorption, biotransformation, distribution, and elimination, ABDE, or A metabolism, AMDE. And for pharmacodynamics, they can be evaluated at non-receptor and receptor levels. Now I will give you some examples how drugs when drugs used together they can cause many effects. This is an example of metabolism interaction and how paracetamol concomitant use with ethanol can lead to hepatotoxicity, hepatic necrosis. So it is expectable that when a person drinks too much alcohol, he may experience headache and may take a paracetamol, an analgesic drug. But here you see the interaction between these two drugs. What is the reason? Ethanol induces CYP2E1 and paracetamol is here metabolized by this cytochrome enzyme. So it will be converted to its toxic metabolite NAPQI. So lots of toxic metabolite will be available. And if the headache is too severe and if paracetamol is taken at very high doses, what will happen? High amounts of NEPQI will be produced. And glutathione, of course, will not be able to overcome this toxicity. Its levels will be depleted, which will lead to paracetamol poisoning and hepatic necrosis. You see here an example of a pharmacodynamic drug interaction. So aspirin is an analgesic, but it's also used for prophylaxis against a stroke or myocardial infarction, ischemic cardiovascular disorders. So aspirin inhibits platelet aggregation. So it will inhibit thrombus formation, hence thromboembolic events, and will reduce cardiovascular risk. And if when it is used together with anticoagulant heparin, depending on the dose, concomitant use may end up with risk of bleeding. Another type of pharmacodynamic drug interaction which can end up with bleeding problem. And for example, ginkgo biloba, this is a dietary supplement. And also you see here the analgesic drugs, which aspirin is a member of. These are non-steroidal anti-inflammatory drugs used, for example, in osteoarthritis. And they also inhibit platelet aggregation. And when these drugs are used, then the adverse effects, increased bleeding, may occur. Let's give another example of pharmacodynamic drug interaction. In fact, these are toxicodynamic examples. So these are the antidepressant drugs, SSRIs. They increase serotonin level. And if it is taken with another supplement, St. John's wort, which can be prescribed extensively, so they will increase serotonin levels, which can result in serotonin syndrome. So the patient with serotonin syndrome will have this diaphoresis and agitation, tachycardia, and most often hypertension, clonus, hyperreflexia, and tremor. So I give you examples. I gave you the examples of toxicodynamics and toxicokinetics. In the second part, I will continue with pharmacovigilance. Thank you.